parasympathetic nervous system. So I'm going to try to finish this today, and I'll see how we do with the rate of us getting this done, and potentially what we'll do on Thursday, if we get far enough ahead, is we'll do a review. If we don't do the review in class, I will post something for you guys to like review on your own, so that you know kind of how to direct your studies. Whenever I have a review, remember it is not, I can't tell you that it will include 100% of your exam. Because sometimes what I'll do is I'll keep looking at your exam, and if I don't like a question, and I liked it yesterday, but then today I don't like it, I might change it, okay? So that's why I don't tell y'all like your review will include everything, but I do try to help kind of direct your study. So if you're not done by Thursday, and we can't do the review in class on Thursday, I will post something for you to review. I will be in Florida, but I will have my phone, I will take my computer if y'all have questions. If it does kind of like push come to shove kind of thing, we could probably do one on Saturday, like through Teams. So I just gotta see where we are, and then I'll keep y'all posted on that, okay? All right, so when we stopped, we were talking about like our uses, what can we use it for? And remember we were saying like, all right, we're trying to get things wet. So any condition that you can think of where something is dry, or it has like a lot of pressure, like the glaucoma, we were going to try to go ahead and ease or wet, give them some fluid to kind of start running, because remember that was our side effects of our cholinergic agonist. So in a sense, we're kind of using these medications because of what their side effects are doing in a way, okay? So that's kind of how you can link those together in your brain. So in our contraindications, just think about situations where these things, our side effects are already a condition that they have. So then we will be compounding essentially what they have going on. So we said that, all right, wet and slow for our agonists and what they were doing, right? So if I'm looking at wet and slow and my heart is, I'm already having bradycardia. So if you have a patient who is bradycardic, you don't want to give them these meds because it could make them even worse, right? It's going to slow down their heart rate even more. Patients who have asthma, because we talked about that and the fact that it could flare that up. Looking at your genitourinary, so if a person has an obstruction and we haven't surgically removed it, or we haven't even discovered it, if you're going to try to make them go to the restroom all the time, and we're increasing the need for them to use their GU system, but there's something that's actually blocking it, now you're going to aggravate that condition for that patient, because we're making something wet that they can't excrete, like they can't urinate, okay? So that's why you'll kind of see those, they'll have more contractions, more pain that would come along with their condition. So if you do see that when you start one of these meds and they're starting to complain about that, then that should be a hit for you, like, hey, let me see if there's something else going on here that I need to explore for. And then your patients who have any peptic ulcer diseases or obstructions, again, because we have increased secretion, we're trying to make sure that we're not worsening any of this for our patients, okay? It's going to make more movement occur, so therefore that can be more painful for some of these patients, all right? So remember, rest and digest, slow and wet, so anything that you have we're using them for their side effects, but if somebody has any of these side effects pre-existing, they're contraindications or warnings, okay? All right. This is kind of familiar with what we talked about previously with where these medications will work. So when we were talking about our alpha and our beta receptors, we were looking at our sympathetic nervous system, whereas our receptors that we were focusing on right now with our parasympathetic was going to be our M1 through M3. We had to 5, but we didn't worry about 4 and 5. We were M1 and M3. So on this chart, let me get my laser. On this chart, what you can see is that we're specifically looking at, for our parasympathetic nervous system, the M3 receptors for some of our medications that we talk about, right? So when we were talking about hitting M3, we said that we were going to have some smooth muscle activity occurring, or a smooth muscle contraction in this situation. So you see like the circular muscle in your ciliary muscle in the eye is what is going to have the contraction that occurs. So that's why we see the miosis. And then when we talk about accommodation is essentially like allowing our eyes to focus on something. Okay, so they're going to contract so that we can see very well and focus on whatever it is that we're looking at. Some people will have a loss of accommodation, so they're not able to have that contraction occur. So all I want you to know is that we're looking at M3, and what happens when we're targeting our M3 is that we're having contraction of that smooth muscle, okay? And then this is, again, just giving you the definition, bringing those objects into focus whenever we have that accommodation occur. Another, instead of in the picture, more so in words, in our drug that we have, so we talk about pilocarpine in this situation. So again, our mechanism is essentially when I hit those M3 receptors, I'm having that smooth muscle contract, and therefore I'm allowed to accommodate. The other thing that we'll see, especially for our patients who have glaucoma, is they're going to have that increased ocular pressure because there's so much fluid built up in the eye. And so what we'll do is we increase the outflow of that humor that's causing that buildup of pressure and sometimes messing up their vision. Will cause that to start coming out, right? Because we're wetting things because I am an agonist. I am a cholinergic agonist, so therefore I'm wetting things. So I have two things that are happening here. I have the constriction because I hit that M3, and then I have the increased outflow of that fluid that has built up in that patient's eye. So therefore we decrease the pressure that they have. So our clinical use, a lot of times you'll see this being used in clinic. Very rarely will we see like these medications given for someone to take home, but we'll go into some more of those that you do see used on a more frequently like outpatient basis. So when you go in and we end up leaving with our glasses after you get your eye exams, there's a lot of our meds that we're going to talk about where we're using them to either dilate or constrict and see how the eye muscles are going to respond to that medication that I dropped in, right? I know if I give an agonist what I'm expecting to see versus if I'm giving something that's an antagonist or vice versa, okay? So we're just using this to diagnose our patient to see what was wrong, if there is anything wrong, okay? Does it function normally? So glaucoma and exams are what we were using that for, pilocarpine. All right, so looking at our big chart that we had, we're going to start talking about our direct acting agonists or cholinergic medications. So essentially, I like to say they're direct acting agonists. Okay, don't worry about the specificity here. This is just telling you that it made it more specific, and we can take medications and put different molecules on them to be more resistant. So we're trying to mimic the effects of our acetylcholine. So when we make a medication, typically we're going to be mimicking it off of something that's normally in our body, right? Like some type of endogenous hormone or what have you, molecule, whatever it may be. When we make our medications, we put different molecules on it so that it doesn't get degraded quickly, so that it can stay around longer. So that's kind of what we're looking at when we're looking at our agonists. We're trying to say, all right, how long can I get them to mimic this activity of acetylcholine? Because if I just have regular acetylcholine, it's not going to last long in my body. Okay, because my body is like, oh, we know you. Versus the drug where we're like, we already know what you're going to do. How can I combat that? So that it can stay around for a little bit longer. All right, so looking at our acetylcholine, typically you won't see us using this like clinically a lot. We'll use it in a clinical setting just to diagnose. This is not something that we're going to send a patient home with. And the reason why is because we're going to quickly deactivate this, right? This is super similar to what we already have in our body. There's not a lot of modifications that have happened when we're looking at this. So when you're looking at our acetylcholine or mycol-E, this is specifically for us using it to diagnose a surgery, like a procedure. We're using it to get the effect that we need in our eye at that time, not something that you're going to prescribe to a patient to like send them home with. So if we were going to try to use something like this, what you would see happening, because it's not very stable, is that they would just be putting eye drops in their eye all day long, right? So the adherence to that is probably going to be very low because no one's going to want to put eye drops in their eyes all day long, right? So we want something that's going to last for a longer period of time whenever we make our medications, okay? So remember, this is causing that constriction, and it's mimicking our acetylcholine that we naturally have in our body. So it doesn't last for a very long period of time. You can use it in surgery, but that's about it. All right, our pilocarpine that we were talking about. So when you're looking at this, again, we talked about our patients who had glaucoma. We also talked about diagnosing some of our patients with using this medication. So on an outpatient basis, the glaucoma treatment, you'll see this used, but more so when we were talking about if you were ordering it for a procedure, they're not gonna go home with it unless you end up diagnosing them with glaucoma. This one also has an oral formulation, so that's something that you need to look out for because that'll help you remember your clinical uses. So if someone has dry mouth because we're doing radiation, or they have Surgeon syndrome, which is like an immune illness that causes their eyes and their mouth to be dry, that's when you'll see this medication used. But we'll use the oral formulation if they have xerophobia or dry mouth, okay? So we have a tablet to help with that. So that formulation makes sense, right? My mouth is dry, I take the tablet. If I'm looking at my patient who has glaucoma, I'm gonna use my eye drops. I'm not gonna have to systemically expose them, okay? Adverse effects, same ones that we've already discussed. When we're looking at our eye drops, these are more so gonna be focused, the adverse effects like that we talked about with our agonists making things wet, are gonna be centralized to that area that we're putting it in, right, our eye. But when you talk about giving a medication orally, now you're gonna have more systemic exposure, right? Because I go through ADWI, it's gonna go through my entire body. So now my adverse effects are gonna be greater than what I would see if I was just applying it to that one area, okay? Because now I took that tablet and everywhere in my body has now gotten exposed to that, all right? So more systemic, more widespread, potentially pronounced adverse effects whenever we're looking at our oral formulation over the eye drop formulation. This is just going into more detail about how a patient with glaucoma has increased intraocular pressure. And so whenever we do our contraction and we hit that M3 muscle, that it'll cause the outflow. So this is more of FYI if you want more background information on what's happening with patients who have glaucoma. Y'all will get this later, but I just wanted it to be here because I know some people like to see the completeness. So remember, our pilocarpine is constricting those muscles, the ciliary muscles, and therefore you can release some of that pressure and kind of open back up that angle that they have in those people who have closed angle glaucoma. All right, buthenicol. When we look at buthenicol, good medication, again, I try to, let me point y'all to this. So whenever you're looking at your slides, I went in and I tried to put, all right, yes, you're looking at an agonist, where does it fall into? So that on the heading of every single one, you kind of can stay along with that big chart that we looked at the very beginning, okay? So just pay attention if you're getting lost while you're flipping through the slides and studying. Like, look at your title so you can remember, okay, like, where's my action? Where does this fall, okay? So with this, we're increasing that bladder muscle tone, essentially, so that we can have relaxation. So in my mind, this is kind of opposite, because when I think of, like, increasing tone, I think of something being closed and not relaxed. So make sure that you're paying attention to the fact that when we're looking at our increased muscle tone, we're having relaxation, and therefore, now I can urinate. Okay, I'm making things wet. So a lot of times we see this used in some of your patients who are going to have several different issues as to why they're retaining. Sometimes whenever you do a procedure and you cath the patient, even like somebody who delivers their child, when they get an epidural, you put in a catheter and you take it out, and then they can't use the restroom after, and you're trying to be like, all right, if you don't use the bathroom, I'm like, can you give me some medicine first? Don't straight cath me, please, right? So you have all of these different medications that you could try before you're doing something like that. So the utility for this is typically in your patients who can't urinate afterwards and they can't relax still after they've had some type of procedure. It could also be some type of damage that has occurred in some of your patients to where they're having that neurogenic atony, and so therefore they're not responding how they should. So this medication will also help their bladder relax so that they can urinate instead of retaining it. Adverse effects, same ones that we talked about, right? So dumbbells, and then your contraindications would be anybody who has these conditions that we already talked about in the very beginning. So asthma, if I have any type of obstruction that's already happening, like I want to avoid this medication. Bradycardia, so just look at the one that had like the squares that looked at what are my conditions and when do I typically use my agonist, and then my side effects or my contraindications. Your side effects are your dumbbells, but my contraindications are typically going to be the same for every single one of these, okay? So it's easy for you to kind of remember this entire class together so that you know, all right, what are my side effects? You got them all for this class. All right, what are my clinical uses? Okay, let me remember these. It's making things wet. So anything, any condition that I have that's drying me out, I'm gonna need these meds to help make me go to the restroom, make me relieve the pressure that I'm having for my glaucoma, diagnosing anything to figure out what's going on with my eyes, okay? So contraindications are listed there. I'm gonna start going through them like that because it starts to get repetitive and then y'all really start looking at me like, okay? So I'm gonna be like, same side effects, same contraindications. All right, now we're looking at our indirect. So remember when we talked about the very beginning, our indirect is not directly acting on our acetylcholine, but it's doing something to prolong the effect of my acetylcholine, right? So that was what my indirect were doing. So all these meds that we're gonna talk about are gonna be indirect. We have our competitive, which was reversible, and our non-competitive, which was irreversible, is gonna form a tight bond, and it's gonna be very, very hard for me. I'm not saying that you can't, but time, and there's lots of things that will play, but when you're looking at your irreversible, time is of the essence for you to stop that bond from aging, okay, and we'll talk about it. So, indirect acting, when you're thinking about these, they're helping acetylcholine in the background, okay, acetylcholine doesn't know this, getting some help. Okay, your edrophonium, this medication is, again, a medication that we'll look at when we're talking about kind of like trying to figure out what's wrong with the patient, so for diagnosis. You'll also see these used to see about myasthenia gravis crisis that a patient could be having. So more of a diagnostic realm whenever I typically see this. You do see also here the non-depolarizing NMDA reversal. So we're going to talk about NMDAs towards the end of the lecture today, but very versatile medication, typically more of an inpatient route. Looking at our mechanism of action, competitive, okay, competitive, so can I reverse that? Yes, competitive, reversible, acetylcholinesterase inhibitor, all right? So again, just trying to help my acetylcholine stay around for a longer period of time without being broken down by my acetylcholinesterase. Short acting, so again, that's why you see that we're typically using this to diagnose because we want to see what's going to happen, right? I'm not giving this to my person to take home because again, this will be one of those things that they would be taking for like all day just trying to use these medications, whether it be the IV route, which is typically what we're doing. So you'll also see sometimes this medication combined with atropine, which we're going to talk about, to wake up someone's muscles after they have a surgery. Because I have that acetylcholine around for a longer period of time, remember when my acetylcholine hits that effector cell, it's going to make it do something, right? So if I need my muscles to wake up, this is typically also where you'll see this medication used. So that's why they're trying to use it when we're talking about myasthenia gravis, which is a disease where like somebody's muscles are very weak and they're fatigued. So they kind of become like very lax and like floppy. It's another like non-medical term. So like when you're thinking about trying to use this medication, if I give it to a patient who might be in a crisis, an MG crisis, I should see like things start to kind of wake them up. So like then I can start to see their muscles moving again. Okay, that's what you should see happen if you give them this and they're in that crisis. So what you can see here is like her muscle was kind of overstimulated, so you see that eye is kind of closed and it's down, and then we gave her the edrophonium, and then her eye is gonna open back up again, right? Like now my muscle can do what it needs to do because my acetylcholine is there making it now be able to like, I can hold my eye open, okay? Same adverse effects, contraindications, same there. So remember what you have for this, and then remember your other indication, the NMPA reversal. Okay, your cure antagonist is what we can use this for as well. Physostigmine salicylate, so I underlined SOS because I try to remember this as one of those medications that can help me reverse the effects of like a toxic anticholinergic, which we're going to talk about. So if there was some type of poisoning, mushroom toxicity, anything like that, like SOS, physostigmine, help reverse the effects of that anticholinergic, okay, with my cholinergic agonist. Again, plant-derived is competitive, and then we see that it's gonna, again, help that acetylcholine last for a longer period of time. So that's your mechanism for all of these drugs that we're talking about that are indirect, okay? So you see it's the same thing over and over again. Onset takes a little bit longer than our edrophonium that we were just talking about, but again, thinking about our SOS, you have physostigmine, right? Reversal of our anticholinergic poisoning that we can have, and then reserving for our treatment of our patients who have very life-threatening symptoms where like we're not sure what the poisoning could be. So I always just think about this and relate this one to poisoning. Yes.
And what did you say that SOS kind of is indicating?
So and just a drop for you guys to try to remember that it's like if somebody got poisoned, toxicity, like SOS helped me reverse whatever that toxicity was. That's just a me. If you don't want to use it, you don't have to. I'm just trying to help drop some little things. When we talk about the monitoring for this, so this medication crosses the blood-brain barrier. And so when we talk about that, we talked about like, okay, what are things and what are my side effects that I typically see? So I'm going to have some CNS side effects whenever I'm looking at this. So one thing that we typically monitor is going to be seizures for this medication. So this is something that stands out for this med. So our SOS, toxicity, I have seizures that are also going to go along with that, okay? Because of how lipophilic it is and it gets into that, our CNS, you can see seizures occur. Adverse effects, contraindications, same things that we've already seen before, okay? So physostigmine is reversing the toxicity, and we need to monitor. We're going to monitor their vitals, and we're going to monitor for those seizures, okay? Because of the lipophilicity of the drugs. Neostigmine. So the way that I kind of remember the neostigmine in that it is like the newer 2.0 of the physostigmine. Mine is all of the side effects. So neo is like new, right? So the new stigmine, neostigmine. And with this, what we said was, okay, we're worried about the lipophilicity of our physostigmine, so I'm going to create this other indirect competitive medication that is not as lipophilic, and therefore I don't have to now monitor those seizures because it's not crossing the blood-brain barrier the same way, okay? So on here, you don't see all the monitoring that we saw. We didn't see the seizures, but we see the same adverse effects that we had before, same contraindications or cautions that we saw previously with our other medication. Looking at our indications again, this one now is also, the difference here is that you also are seeing this used for treatment, okay? So now I'm treating my patients who have myasthenia gravis with this medication, okay? And then my onset of action, taking a little bit longer than our physostigmine, 10 to 30 minutes of us having this medication kind of get into their system and work. But again, a good medication. Also, you'll see this, not typically used for this, but what you can see, some people are very sensitive to this medication and they'll start to have GI issues occur, so they'll start to have diarrhea while they're taking this medication. So the longer that they're in that MG crisis, the more likely you are to see them end up with diarrhea, because remember, this is going to increase that motility. It's going to make things wet, so therefore you'll see more defecation in those patients. Also, reversing those NMBAs that we're going to talk about. So any neuromuscular blocking agent that we could have given, let's say we gave them too much, we can use this medication also to reverse it, okay? Different formulations, just be aware, don't need you to like commit those to memory because there's not a big thing with that, okay? So this one is treatment, Whereas when we were talking about our edrophonium, we were using that to diagnose our patients with myasthenia gravis. This one, we're talking about, I can now treat their symptoms that they're experiencing whenever they come into the hospital. Most of the time, these patients will end up in the hospital. All right, pyridostigmine. Don't mix this up with your physostigmine, okay? Pyridostigmine is kind of like your neostigmine, but this one, again, it takes a little bit longer. It has a longer acting effects, and you don't see as many GI issues when we're talking about our pyridostigmine, okay? So again, how I was telling you, a lot of times when we're treating our patients with our neostigmine, we'll see a lot of those GI issues occur where they have the GI upset and the diarrhea that's very pronounced for your neostigmine. Here, you're not gonna see as much of that, and it's longer acting. So when you have things that are longer acting, sometimes what you'll see is that because it's released over a longer period of time, that you don't have as many side effects as you see with something that's released a little bit quicker, which is what we kind of talked about when we were looking at our PK lecture. So longer duration, fewer GI upset, and our side effects that we had. Clinical indications, very similar to what we just saw with our neostigmine. So we're still talking about treatment of our myasthenia gravis. And then the reversal agent, when we talk about our NMBA, so I can use this to reverse the effects, especially if I have too much, I gave them too much, I can use that. And then for our nerve gas exposure prophylaxis, so this is important for us as active duty, and even if you're not and you get activated. So nerve gas exposure prophylaxis, so if we know that that's something that could be the enemy's plan, what we would do is we would give out this tablet to our patients. They'll take one every 8 hours. So while you're fearing any type of nerve gas attack, you can start giving these medications. They're usually in kits that we have. So just kind of thinking about that set that you would have. Adverse effects, cautions, contraindications, all of them are the same. Okay. Also, I wanted to point out that you'll see this this tablet set, sometimes abbreviated as SNAP. Okay. So the Soman nerve agent pyridostigmine pre-treatment. SNAP. Okay. When we're looking at our irreversible acetylcholinesterase inhibitors, another way to think about this, and you can write this on here because it's an interchangeable word, is organophosphate, okay? And so when we're talking about these, typically you're gonna see these used as poisons or toxins because they're irreversible, right? So if I want to kill something, if I wanna make it die, whether that's a weed in my yard or a person, I can use one of these irreversible acetylcholinesterase inhibitors, and therefore I can see that toxicity occur. So what happens is my acetylcholine is going to increase, and then that can lead to those detrimental effects, like I can start to have seizures, I can start to have respiratory arrest, a coma, like my muscles are going to get tired eventually from being stimulated, and then they can stop. So when we talk about treating the reversal, when we talk about reversing the effects of these agents, we're going to look at some of our anticholinergics, which can reverse the toxicity effects that we'll see if somebody is given these as a poison, or if they take like mushrooms or something like that. And we got to figure out how we're going to help these patients. This is kind of our anticholinergics. We'll talk about some of those. And then we just talked about some of our agonists that we have that can help with that, like our physostigmine. So some of the examples that you have are your ecothiopate, your sarin, and your parathion. The sarin is the one that we're typically hearing about when you do like CBER and things like that, because that's the warfare agent that you use. Your ecothiopate, these are typically the ones that we're going to use for glaucoma. I think we'll briefly go over that. And then your parathion is ones that we use when we're talking about like pesticides outside, things that you're using to kind of protect your house. But if I was out gardening and I got a big whiff of it while I was gardening, I could potentially poison myself depending on how much of it I inhale, or if somebody put it in my coffee. Okay, So these are, again, your organophosphates that are going to irreversibly bind to your acetylcholinesterase inhibitor. When we're looking at our ecotherapy mechanism of action, again, it's in our name, right? So our indirect cholinergic agonist, and then again, this one specifically is working on the eye. So remember your E with your E. Okay, so contracts that muscle. This is the only one that we have that is an irreversible agent that we use on a daily basis for our glaucoma. Both of the others that we'll discuss are going to be toxic meds that are used to poison or to kill something. Okay, so this is our only one that we have that is used on a daily basis. I don't typically see this this one prescribed because we have so many other meds that are great for glaucoma, but this is an option that we could have. So again, adverse effects are going to be the same things that we have already talked about with all of our previous medications. This is just a review of us kind of going over how we talked about acetylcholine is the main thing that I'm worried about when I'm looking at my parasympathetic nervous system. And so when I'm talking about acetylcholine, I typically am going to associate this with Alzheimer's disease because we're thinking that there is a decrease in the amount of acetylcholine that I have available. So when we look at our medications that we use, we're going to try to see if we can increase the availability that we have of acetylcholine around to work, make their symptoms not be as dramatic as they are. So there is still no cure. We're essentially trying to slow down the progression and make the patient have a better quality of life, I guess is what we could say with that. Okay, so big thing that I want you to remember here is in our CNS, that's where we're going to look at some of these medications that are going to help us with our Alzheimer's disease. So again, I already told you that we have less acetylcholine in this disease, so what we're thinking is, okay, if I give an agonist, right, I'm going to increase the amount of acetylcholine that I have around. Or if I give an acetylcholinesterase inhibitor, I can still get the same effect. I'm increasing the amount of acetylcholine that I have around. So again, the big idea here is that you are slowing the disease, you are not stopping the disease. This is a progressive disease and it does get worse over time. Okay, so your patients will start to come in and you will see them declining. This is just kind of keeping it at bay for as long as we can. So when you talk about this, their issue is that they have less acetylcholine. So what we are trying to do as providers is say, okay, what medications can I give you to increase the amount of acetylcholine that you have around so that you have less side effects or less symptoms? Yeah. So typically we don't preemptively give something because these medications do have a lot of side effects. You're watching them more closely. I have not seen any situation where, because you don't know what age it could be, right? Like I could have this happen to my mom and she was 70 years old, and then I could have it with my dad and he was 80 or he could have been 60. So like the time to put someone on a medication when you're not knowing exactly what you're combating, I haven't seen them doing that in my experience. So when you get to your allergies and you have like somebody who is practicing more than I do in the like medication room, you can see what they say about it. For me on our side, pharmacy side, I haven't seen us like say, I'm gonna prophylactically treat you having Alzheimer's. I haven't seen it. So, good question. On my side, no, we haven't done it. But I don't know if on y'all side, would you actually do something like that, or what studies would say about doing something like that? So when we look at our inhibitors, okay, so acetylcholinesterase inhibitor for Alzheimer's disease. So I now know that ultimately what's going to happen to my acetylcholine is that it is going to go up. So my mechanism of action is inhibiting the acetylcholinesterase, which is breaking down my acetylcholine. I don't want my acetylcholine broken down. I want it to stay around for a longer period of time. So the acronym that we have is Take Care of Grandma, right? So it's based off of the brand names of the meds, which you will have. So your Tacrine or your Cognex, donepezil or Aricept, galantamine, which is Razidine, and your rivastigmine, which is Exelon. The good thing about Exelon, and when we're talking about Alzheimer's disease, is that some of your patients will kind of become not necessarily combative, but feel like they don't need the medication because they're not as aware as they were before. And so you have issues with them swallowing medications or taking medications, depending on how they present. Some people may be paranoid and think that you're trying to poison them. Okay, so you don't know kind of what's going to go on. When we talk about our Exelon patch, it's a patch. So therefore, I can put it on them, particularly in a place that they may not be able to reach it or see that it's there. And they'll get that medication, but now I don't have to fight with you every single day to try to make you swallow a pill or have them cheeking pills and you're like, open your mouth, let me check. I can put on a patch. So that's the good thing about the Exelon or your rivastigmine patch, okay? So remember, irreversible or acetylcholinesterase inhibitors that we're having. I want to make a note so that people kind of don't mix this up because now we're talking about the disease and this isn't necessarily saying that this is like an irreversible agent, okay? So I don't want you to mix this up with like the irreversible agents that we were just talking about, okay? We're just, this is a drug class as a whole and these are our indirect acetylcholinesterase inhibitors, okay? Just don't want you to get confused. All right, so now we're gonna talk about our anticholinergic agents. So think about everything that we just said, now we're doing the complete opposite, okay? We're flipping the script. So when we're looking at our anticholinergics, this is like a summary of all of the mechanisms that you're gonna see. So your MOAs are a little bit different here, and they're a little bit more all over the place. So what I did was I took your indications that you're using them for, and then put the meds under there so we can kind of keep track. So it's not the same tree branch that we had when we're looking at our cholinergic. This is now more so like, hey, these meds that are, here is their mechanism of action summary. And then looking at this, almost all of these are going to be targeting a muscarinic receptor. So as we go through these, you'll kind of start to see the repetitiveness in this also. And then looking at, again, some of our antagonists that you have. So I told you most of these are going to fall on your muscarinic receptors. So here are almost all of the meds that we're going to talk about. When you're looking at your nicotinic receptor antagonists, we have our competitive and then our non-competitive. So we're going to talk about these. And then these are the classes of our competitive and non-competitive. Okay? And then all of these down here are going to be your NMDAs, okay? So your neuromuscular blocking agents are both of these, but not, that's the umbrella term for it, okay? So we'll talk about those. There are other things that you could say are anticholinergics like Benadryl, but we talk about that in a different capacity, so it's not listed here. Okay, so this is not like an all-inclusive list of everything that can be considered an anticholinergic. We're going to deal with some of that stuff later when we talk about other disease states, okay? All right, so looking at our overview of what our anticholinergics are doing. So we have these different muscarinic or nicotinic receptors, which we talked about on the very beginning of the lecture. And so now we're using our anticholinergics to target these different receptors. So anti-muscarinic is what you'll hear if we're talking about that M receptor, so our M1 through M3 being targeted, whereas your N sub-N antagonists are going to be ganglionic blockers. Usually with these, we don't see a lot of utility with them. They're not fantastic, but we'll talk about them a little bit. And then your N sub-M is going to be your neuromuscular muscle blocking agents, or your NMDAs that we're going to talk about. And then with this, our side effects are going to be, so if I was wetting stuff before, anticholinergic, I'm now drying everything, okay? So complete opposite. all right? So drying things up, you're gonna see we had bradycardia, right? We said wet and slow with our cholinergic, so now we're gonna be dry and fast. So I had bradycardia before, now I'm talking about tachycardia. All right, whenever I'm looking at the eyes, I talked about constriction when I was talking about my cholinergic agents. Now when I'm talking about my anticholinergic agents, I'm talking about dilating, opening up, okay, when we're specifically looking at the eye, okay? So a lot of the times if I dilate too much, they can't accommodate, okay? And so, which is what we were talking about when we were looking at our agonists. So they can't accommodate, and therefore you'll see what's called cycloplegia, where they can't see near, right? Because now I can't focus, and so they lose their accommodation essentially. This is a little note. I don't know. It's supposed to help you remember: blind as a bat, mad as a hatter, red as a beet, hot as a hair, dry as a bone. The bowel and the bladder lose their tone, and the heart runs alone like tachycardia. That's too long for me to remember. If I remember all that, I might as well remember all these side effects. Okay? so dry, your heart is sped up, and now we have our dilation instead of the constriction, okay? That's a little bit less for me. Okay, so when we're looking at our uses, okay, this is when we're trying to, again, dry things up. So I have some type of condition where maybe I'm using the restroom too much. You have some situations to where you're wanting to cause sedation, or like there's some motion sickness going on. And so we have some patches that we're going to talk about when we're looking there. Let's say I'm having a lot of contractions in my GI and I'm going to the bathroom all the time, and it's diarrhea going to the restroom, and I'm like, all right, doc, I need something to help me, right? Like, these are our meds that we're going to typically go to when we talk about our poisoning, right? These are some of our meds that we can also use to reverse the effects of those organophosphates that we talked about. So when looking at this, just kind of think about any issue that I could have. Also looking at bradycardia, right? So if my heart rate is too low, I can increase that if my heart rate is too low because of my side effect of the tachycardia, now I can increase that heart rate that I have in my patient who might be bradycardic. And then you also see, before we said, oh wait, watch out for my patients who have asthma. I don't want to use this because it could cause them to have that bronchoconstriction. Here, you see that I'm relieving it, so I can do some bronchodilation with these medications, okay? So just think about the complete opposite of what we learned in the first half is now going to be applied to what we're going to look at in the second half. And then with our cholinergics, we had Alzheimer's disease, so our agonists, we had those Alzheimer's disease, whereas when I'm talking about my anticholinergic, Parkinson's disease, okay? So remember which disease goes with which medication that we're going to use, okay? All right, so our first medication that we have, and like the one that they kind of base a lot of our meds off when we're talking about our anticholinergics, is going to be our atropine. So it comes from a flower, and when we talk about belladonna, and you talk about, bless you, some of the different things that we used to do back in the day, wives used to poison their husbands, because you know they say wives are like the ones who are, or women are likely to poison. They used to poison their husbands by putting some of these berries. And then you also had in some countries where they think to have like the dilated pupils is very beautiful. So you'd have some people who would like use this to like have dilated pupils, which I don't know how they saw anything, because you can't focus. That's not fantastic. So atropine is like our OG, like our original one that we kind of based everything off of. So when we look at our mechanism of action, again, it's trying to say, hey, acetylcholine, you're doing too much. Stop, right? I'm inhibiting my acetylcholine, okay? I don't want anything to move. I want everything to just relax and be still. Anticholinergic, anti-acetylcholine, okay? Stop. stopping my acetylcholine from doing that action that it's typically doing. And then you see that it blocks all of my M subtypes that I talked about. So specifically when we're talking about our meds, our M1 through M3, we're blocking those, okay? With our effects that we see, you see that we said we're gonna dry things up when we're talking about these meds. So I have less secretions if somebody is having like a lot of secretions. So you'll have sometimes where you're doing procedures on someone and you don't want them to be very wet, right, in their mouth. So I need to dry them up. This is sometimes where you'll see us using this, okay? So less acetylcholine, I have less activation. I have less secretions, okay? So again, when we're talking about this, also remember that you're gonna be working in your parasympathetic nervous system, and also you'll see some of these effects happening in your central nervous system as well. May reduce the paralysis that we were talking about that could happen with our organophosphates. So I can reduce some of those effects on the CNS if I have atropine around. And then we also look at this when we're talking about asystole. So like let's say you're having a patient who's coding. You'll see sometimes this in our, well, all the time, this will be in your crash cart. So if there's a code, you'll see where we're gonna give some of our patients atropine, and then also preventing or trying to stop again that bronchoconstriction or like the bradycardia that we can see in some of our patients. So a lot of the times when I am in an inpatient setting and I'm seeing atropine, it's usually because we have somebody coding and we're doing CPR and we're in that code and we'll use several boxes sometimes of our atropine, okay? So that's typically where I have used it. Yes.
So if you're trying to get the heart going, or if they're coding or something like that, and you're trying to decrease ACH, wouldn't you want to increase ACH so it can contract harder or faster?
So in this situation, essentially what you're looking at is like, especially, it depends on what has also caused it, right? So like when, and y'all will learn all of the underlying issues that can make someone code. Depending on what it is, there are sometimes issues that like if I poison you, this is going to be something that I'm going to need to get those agonists off of that nerve, like to get it off of my acetylcholinesterase inhibitor, or if it's just if I have now overstimulated you to where now you are bradycardic because you're in that state, right? Because remember, wet and slow when I'm talking about my cholinergics. Whereas when I'm talking about any of my anticholinergics, typically you may see some tachycardia. This is one where you're going to see like a lot of tachycardia if you administer it. So when y'all go through like learning, trying to figure out what's caused someone to hit that bradycardia, it's crazy when you're in a code. And like all of the labs that they're running, you're checking gas levels, that's all of y'all's work. I can't even tell you where to begin. I started to learn it and then my residency was over. But it's a lot of like underlying, you're looking at acidosis, alkalosis, like there's a whole bunch of stuff that you're looking at underlying to figure out what caused it and why you're correcting the way that you will. So yes, it sounds counterintuitive, but it will cause tachycardia in your patients who have bradycardia. We'll do this slide and then we'll do our break. So our indications, again, your bradycardic patients, your patients who are crashing. We're talking about the eyes, just trying to use this more so for diagnosis rather than we're looking at treating some of your patients. GI issues, so if I'm going too much, I'm having a lot of spasms, a lot of cramping, this is very, very useful for that. And then our overdose with our cholinergic agents that we have, so I can reverse it, right? Because I'm doing the opposite of what my cholinergics are doing because I'm called an anti-cholinergic, okay? So I can reverse all of those things, and we'll talk about apnea and some of the other meds that you see listed here. And then there's several different formulations for these drugs that we're going to talk about, looking specifically at your atropine. You see that I have IM, IV, I have oral, several different formulations that you can use. You have your eye drops, and very rarely have I seen us using the ointment. Because of my effects that I can have, you see that we have our monitoring specifically making sure you're following their vitals. And those mental status changes, because sometimes you'll see where some of your patients can potentially, you giving them too much and now they're super alert, or you can also use this to say like, hey, when people sometimes are very bradycardic, they start to be delirious. And so you can be like, okay, they're still in that state of delirium, maybe my meds aren't working. Like, so just following your patient, essentially when you're having to use this, they're gonna likely be in the hospital. And you're likely using this whenever there's some type of like extensive symptomatic bradycardia. And then adverse effects, like you drive things up too much, okay? When we come back, so 10 minutes, so 11.
That's what we're talking about. Reversing, say like if they have spastic paralysis, we want to like say we go Parkinson's, we want to say like heart. That's kind of what I was getting at. Like it's like if the heart's being overstimulated, you want to give them anything that's going to decrease ACH. Is that right?
Well, yes. So in a
And I can get away from that whole idea. That's not like a big thing. I'm trying to correlate it with
I know. That's what you're supposed to do.
Mainly I'm just trying to clarify, like, just give this very decreased ACH and perhaps use like a spastic paralysis or something. And then stay with me. Now we gotta get new ID cards. My ID card says COD on it. Oh my god. I did not expect that. He said something? Yes, sir. Let's do it. Everything. I can tell me I can retire.
goes back. So like they didn't permit she's going back tomorrow and not work. At Shadow, like yeah, like you got the job. She's just like, well, I Shadow. Yeah, like yeah, I guess maybe they're trying to see like yeah. But like but how I see is like like if they want somebody to work closely with us, like a shadow, like they don't have to shadow unless they change their personality. Like just checking the box. Yeah, right. That's what I think.
How are you gonna have me shadow? Like I'm not gonna get my
Well, I know. I've seen like that, like office and stuff. Like yeah, like she's like they'll even confirm that you have the job. Like whatever. She's going back to she really wants a position because like a lot of stuff and then like at that position they don't certify as MAs to do everything. They all get certified to do guessing and once you get
when I text you about the MOA, because I was looking at the first one, and it wasn't in that format. And then they only went to that
Oh yeah.
yeah.
Alright, you ready? Okay, so finishing and kind of recapping when we're looking at this, what I did want to say is that most of the time now when we're using our atropine, and when y'all are doing ACLS, like lots of things are gonna be ran at that time. You will figure out what is causing, or what is the underlying cause for the A system or the bradycardia, and I shouldn't say A system. We used to use atropine for asystole, and then they update the guidelines, and as they continue to update the guidelines, you will see things fall in or out of favor. So right now, I guess the thing to kind of commit to memory is more so like you're using it for patients who are experiencing bradycardia. The other thing that I wanted to mention, I'm going to go backwards a little bit, is when you're looking at things, The generic names are the ones that are not in parentheses. That is what I'm expecting for you is to know. The brand names are the ones that are in parentheses, and that's like for your awareness, okay? So I will put them on the exam because I do know that some people remember brand names. So like when they're studying, because like sometimes the brand names are very, they let you know what you're using the drug for and some of them. So I do typically like have both the brand and the generic on the exam, but you are expected to only know the generic name, okay? Typically also your generic names will not be abbreviated. These are, capitalized. These are capitalized because they're the first thing in the sentence, okay? So watch out if you have like an exam question, you may see that drug name it's in there, but it's not gonna be capitalized. So if I were writing about dicyclomine, I'm not gonna write a capital D in the middle of that sentence, okay? Like it would be lowercase because it's not a brand name medication. If it's a brand name medication, then that's when you capitalize it. So I just want to go back to just regular etiquette when we're talking about our drugs. Okay, so when we're looking at our pilodoxine or 2-PAM is essentially saying, hey, cholinesterase, I know that you have this inhibitor, and now I'm going to try to get rid of that inhibitor that bound to my cholinesterase and reactivate it. So if I can kick that cholinesterase inhibitor off, I can now let my cholinesterase do its thing, okay? So when we're looking at this, just kind of think of, this is saying, and you see here where it says it's phosphorylated with an organophosphate, right? So that means that I have experienced some type of poison from those organophosphates that we talked about, and now I'm going to say, hey, give them pralidoxine, give them this 2-PAM to try to reverse the effects of those organophosphates that we came into contact with. Now, time is of an essence when we're talking about giving this medication. The longer you take to give the medication, the older that bond becomes. So what this drug is trying to do is slow the aging process to where I can recover that cholinesterase, okay? I'm trying to get that activity back. If I take too long to give this medication, now that bond is solid, right? I've been together longer, I'm more secure, I'm stable, and now I lost that cholinesterase. Whereas if I try to immediately give this medication after somebody's been poisoned, I'm more likely to be successful because I slowed down that aging process to where I was able to kick it off. So that's why when I was telling you like irreversible, yes, right? You said that these were irreversible, but if I can beat it, or if I can have it to where that bond is like this and not like this, I'm more likely to be successful. So time becomes the factor. Because if I'm like this, in that aging process, now it's old, I'm less likely to have that reversed. I can't do it. Okay, so that's essentially what all of this is trying to say, right? So this places the organophosphate from your acetylcholine receptor site before that aging can occur. The longer that I have that aging occur, the less likely I am to have this medication be effective and actually works. So therefore, I can reverse the paralysis that I am going to see some patients experience, and that's what's going to kill them. If I can't breathe, if my lungs can't move right, if my heart can't move right, I'm going to die. Yes. Did I answer the question? Sorry, I had it. Okay. So that's what we're looking at here. That's the big thing. So with this medication, time is of the essence. Get it there quickly so that I'm not trying to reverse that bond that's already been formed. Okay. Detoxifies, kind of the same thing. This is what you'll see a lot in your kits. We have the Atna and the Canna that can be administered. And again, we're just trying to make sure that we are not having that paralysis of their respiratory system or of that heart. Because if those go, if my lungs go, my heart goes, I'm gone. All right? Looking at, again, our indications that we have. So antidote for the treatment of those pesticides that we can see, or our organophosphates that we could come into contact with. And then our overdoses of any of our anti-cholinesterase drugs that we talked about whenever we were looking at our cholinergic agents, okay? So essentially, if I give them too much, I can right? I can use my pralidoxine, my anticholinergic, to reverse those effects that I was experiencing. If I had toxicity with one of those organophosphates, I can now reverse that when I have my pralidoxine on board. Okay, so I'm trying to do the opposite of what they were doing. Your adverse effects, lots of them, right? Again, just remember you're drying things up. Remember that I don't have the ability to accommodate, so my vision is going to be probably distorted, whether it's blurred, whether it's now like I can't see from far away, or I can't see far away, diplopia, or seeing two of things, again, because of the lack of being able to accommodate, right? Because now my muscles aren't working, my muscles aren't contracting how they were supposed to. A lot of people ask whenever we're looking at this medication, you see that the adverse effects, muscular weakness when given parenterally to normal people who have not been exposed to any type of poison. So if you're suspecting it and you give it, and you're like, well, how do I confirm it? Benefit is definitely going to outweigh the risk when we're looking at treatment with this medication, right? Because if they're in the hospital and I'm giving this, I'm monitoring them. They're hooked up to everything. So if all I'm worried about is some muscle weakness versus somebody dying because they actually were poisoned and I didn't treat them, I'm going to deal with the temporary muscle weakness, right? Versus your person dying because you're trying to figure out and wait on your tox screen to come back. Treat them, okay? It's not something that is going to stay in their system for forever to where they're going to permanently be paralyzed because you gave them this medication, if they didn't need it, okay? So that's where you see this benefit outweighs the risk. So just try to treat your patient. Worst case, they're going to be a little flaccid for a little while, and then they'll wake back up, okay? But they didn't die though. All right, our medications that we have, our muscarinic medications that we have, they're going to work on our muscarinic receptors, right? We had our M1 through M3. More specifically, we were going to be looking at our M3, okay? So this is the same slide that we saw before, but now think about the opposite, okay? So when we're looking at these medications, they're going to do the opposite of what we said our cholinergics were doing. We said our cholinergics were helping with that accommodation, they were helping with that constriction or meiosis, and now we're doing the opposite, okay? So we're going to get dilation, and we're going to get the loss of the accommodation when we're using any of our medications that we're talking about here. So you have your atropine, your cyclopentolate, and then your tropicamide that you have. So when we're looking at the difference in between these medications, and we talk about typically what we would want to use, you see that your atropine, again, I don't need you to remember the doses, but you see that your atropine, your time to recovery is over 2 weeks. That's a long time. So think about if you were trying to diagnose a patient, or you're just trying to see what their reflexes are, right, when you're doing an eye exam and you give them atropine, they're going to be dilated for quite some time, okay? Not comfortable. Whereas, when we look at our, your tropicamide, you see 1 to 6 hours, okay? So not so bad. You still need somebody to drive you home probably after you have your procedure, but it's not going to be as bad as me telling somebody for 2 weeks that they're not going to be able to have any of their accommodation, blurred vision, all of the side effects that we just talked about, okay? So just looking at this and kind of how you can read things is important. So if you were to see something like this, this is our ideal medication, right? I have a quick onset, right? So I have that quick mydriasis, or my peak to mydriasis, or my peak to the dilation, right, is very quick. So that's a good thing. And then I also am seeing like, okay, this is the best one that's wearing off. So I like this over trying to use this. This isn't horrible, but this is better because I get my vision back quicker, all right? So looking at our uses, again, our diagnostic procedures. I have a question for y'all. Did that cover your notes on this? Because y'all save this PDF. Oh, forgot. I did research about the PDF thing. So what anybody else who had their slides cut out? Not supposed to help each other. Okay, so if your slides are chopped off, like how it was when you're downloading it, they're saying when you download it, you have to download it as a PDF, and then say that you're going to print it, and then save it as a PDF, okay? So don't actually print it. When you put print, select Adobe as to where you're printing it to, and then that saves it, okay? I will repost slide 50. Okay, I'll repost this one for you guys so that it has like your clinical uses on there. So again, it was essentially what we talked about, which is what I was pointing out down here, right? My diagnostic procedures, and then looking at my side effects that I'm gonna have, right? Were the same things that we talked about with this drug class, is that I'm going to cause dilation or that cycloplegia that I have because my muscles are not constricted, how I typically would have saw them if I were using an agonist or if that acetylcholine was around, okay? Adverse effects, drying things up, and then that inability to focus and the sensitivity to light, right? Because now you have me in this dilated state. So that's why I just think about like an eye exam and where you have them wearing the glasses afterwards when you're walking around, okay? Our GU meds that we're gonna use, we're gonna talk about these. You're gonna see these a lot. You're gonna prescribe these probably a lot, especially in our older patients. So normally we'll have like our rest and digest, right? You relax and you're gonna go to the bathroom. When we're talking about our sympathetic nervous system and like fight or flight, the last thing we're thinking about is going to the restroom, right? Like you're like concerned, I don't have time for that right now. I'm ready to handle business, okay? Gotta fight. So when we're looking at this, our rest and digest, we want to try to have them relax and go to the bathroom. When you're talking about your anticholinergics, think about the opposite, okay? It's kind of like our sympathetic, right? I'm drying things up. So I'm not going to the restroom right now, okay? I'm retaining all of those things, bless you. So an antagonist that decreases the muscle tone, and therefore you have the relaxation that's gonna occur at the detrusor muscle, which then causes your constriction, when we're talking about like our sphincter constriction, okay? So ultimately what you're gonna get now is you're retaining. You're not gonna be able to go because now we have relaxed things that we would typically want to be constricted. Okay, so just think about it as the opposite of what we talked about when we were talking about our cholinergics that were making people use the restroom. Now we're trying to do the opposite. We're decreasing that tone, which happens by relaxing the detrusor muscle, which constricts the sphincter, and therefore we have retention. Adverse effects are going to be, again, everything is dry. Now, this doesn't mean also that I don't just have to go to the bathroom. So a lot of your patients who you're trying to help them from not having that incontinence that they have where they're like having urgency all the time. Now, with this, you can also see, because a lot of these are going to be oral medications, you can see that a lot of your patients are going to experience dry mouth as well. Okay, like it's drying up, because remember from oral, I have more systemic, more widespread adverse effects than if I'm just putting it to that site that I need to go to, like an eye drop, okay? So our clinical indications, if someone's going to the bathroom a lot, urinary retention now, right? I can stop that, I can help them. Okay, a lot of times we'll give these to our patients who are waking up several times in the middle of the night to use the restroom. These are our meds that we're gonna use, so that's why I was saying you're gonna use these quite a bit. Here are all of our medications that you have available. So your oxybutynin, tolterodone, your sulfenacin, fesoteride, tospirium, and your darafenacin. All of these medications are good medications. We have them available. If you have someone who's experiencing a lot of side effects, you see your long-acting and your extended release. Those are less likely to have the very extended side effects because we're releasing them a little bit slower. Again, if you look at our patches, you see that your patches have less side effects because they're being given over a longer period of time, going through that matrix that we have when they attach the patch to their skin. So you see how, like, for instance, with our oxybutynin, you're dramatically decreasing the side effect occurrence when you're giving it to them in a patch. okay? So if you find that like, hey, this medication is a great medication for that person, and they like it, but they're saying like, oh, my mouth is super dry, or now I'm constipated, if I give them the patch, I can drop the incidence of that happening. Doesn't mean that it will go away for that patient. It's likely to go away for that patient, but it can still happen, okay? So now we're seeing where like our formulation can change like the incidence of the side effect. All I want you to know from here, do not try to remember all of these percentages. Remember that these are my drugs. Here are the most common side effects that I'm likely to see: dry mouth, constipation, and that vision being altered. Especially if I have it in an oral formulation over me using the tablet formulation, okay? Immediate release, more likely than my long-acting. So my best, or the one that has the least incidence of side effects, would be if I have a patch formulation. Then I could say, okay, if I don't want to use a patch, my best option to use is going to be my long-acting or extended release over an immediate release tablet. Also, what you'll see is the incidence kind of decreases because some of these are newer. So then when we said, hey, we see that this is a huge issue, we made it to where the meds aren't as likely to cause some of these side effects. They still do. So a lot of these medications down here are newer meds that we have, so that's why you see it dramatically decrease, whereas these are our older medications. So that's what they're telling you. They are better with the side effects, but they cost more. So if somebody was going on the outside, you're likely to see that these meds cost more than us using one of these top two. Okay. All right, our GI meds that we have. Looking at this, typically we're going to use these medications when we're talking about like people who have IBS or a lot of cramping. This will kind of slow that down for those patients. So mechanism of action, stopping again that acetylcholine. When we're looking at our indication, IBS, right? Because I'm going to have a whole lot of cramping, my stomach is uncomfortable, and I'm trying to slow all of that down. Your adverse effects are the same ones that you see. What I want you to pay attention here is that we use this medication quite frequently, and it's dosed several times a day. But what can happen with some of your patients is a lot of them will tell you that they experience drowsiness with this medication, okay? So please pay attention to the fact that we have drowsiness, and you look at it as this tiny little pill that seems super harmless, and it is something that we have seen a lot of our patients come back and say like, hey, like I can't drive, I'm really dizzy, or I'm falling asleep now during the day while I'm at work. Like big thing that you can kind of hear a lot about. And then the psychosis or delirium, so watching out for your patients who already have or predisposed to having any type of psychosis, right? So some type of psychiatric diseases, just watch out when we're looking at this. And then diarrhea, so we should be seeing that we're drying things up, right? But if you're still seeing that someone is going to the restroom a lot and I haven't been able to slow down their motility, that is your sign to say, hey, there might be something else going on and we need to take a further look at this, and then we would stop this medication. Because it hints at, and not saying that it's 100%, but it hints at the fact that there's some type of obstruction somewhere else that we need to be looking at as to why this patient is having these spasms, okay? So if diarrhea occurs while they're on this medication, we should stop this med, okay? All right, your belladonna alkaloids. So when you look at this, please make sure that you're seeing the fact that all of these medications are in this one medication, in this one pill. So you have hyoscyamine, atropine, scopolamine, and phenobarbital all into one pill, okay? Essentially what you're gonna see here is that we're causing or lessening the firing that we're gonna see from our, due to the acetylcholine, and therefore I'm gonna slow down the GI peristalsis, I'm gonna slow down the secretions, I'm stopping those things from happening, right? Because I'm anti-cholinergic, anti-acetylcholine. So that's why you see those side effects occur here. Indications, you'll typically see this used in conjunction with other medications. We have several medications when we talk about IBS. We have several medications, so you'll usually see this used in conjunction with one of those medications. Very rarely do you see it used alone unless you're using it for like some of the ulcers or enterocolitis. But when we're talking about IBS, which is something that's becoming more common now, you'll see this kind of as an add-on to that. And then again, those CNS effects are still there. We're still worried about those when we're looking at this medication, so our belladonna. All right, our medications that we're gonna talk about for our lungs are anticholinergics. So when we get into asthma, you're gonna talk about this a lot more, so you'll see these slides come back up again. So our mechanism of action is it is causing bronchodilation. So remember when we talked about our cholinergic agonists, we had constriction, which is why we were worried about our asthmatic patients. Here are my anticholinergics. I want to use these on my asthmatic patients because I'm going to cause some bronchodilation. And an added benefit to this is especially in some of our patients who have excess excretions and secretions where we're talking about like in their chest, we can use this medication to kind of help dry those up as well. So very good class of medication is very common because we have lots of patients who have asthma and COPD, and this is a part of their backbone sometimes of the medications that we use, especially if our beta agonists that we have aren't working. So when we look at this, just pay attention again to your side effects. Very the same ones that you see, but they're limited because of the fact that I'm doing an inhalation, so I'm taking a puff of this medication. So this is going to come just like how we think about albuterol inhalers. These are inhalers, okay? So you have your ipratropium and your tiotropium. When you look at your ipratropium, this one is a short-acting medication. Again, don't need you to remember the doses. Just look at the fact that you can use this for your asthma patients, and you see these sometimes used in our COPD patients as well. And then your tiotropium, again, don't worry about the doses. Understand they're inhalers. I don't need you to remember all the detail. But with this one, you see that it's long-acting. Okay, so I think about my tio or uncle as somebody that's old, right? Like, so that's how I remember it's long-acting. They've been here for a long time. Okay. Compared to a beta-2 agonist, you see your anticholinergics have similar or greater efficacy for COPD, but less efficacy for asthma. And we're going to get into this a lot more whenever we talk about it. But just think about when we talk about asthma, we have exacerbations, which is where they have like a flare-up, essentially, of their asthma, and they'll have a lot of constriction that occurs. So when we look at this and we talk about less efficacy for asthma, that's because we're trying to decrease the exacerbations, and these aren't necessarily decreasing the exacerbations, and therefore you're likely to have an asthma-related death. So that's why we kind of, we'll go over this when we're talking about our beta-2 agonists versus our anticholinergics, because they're going to help us with actually saying, hey, dilate. Stop this exacerbation. We'll go over it in more detail. So just remember, when we're looking at our beta-2 agonists, these aren't as effective as in asthma, but when we're looking at COPD, which is a different respiratory condition and a disease, they have similar or equal efficacy, okay? Nausea and vomiting. So when we talk about scopolamine, this drug has been around for a very long time. Good medication. We use it for people who are doing surgery, and let's say they get very nauseous after they've had anesthesia, and they're telling you like, hey, I don't want to feel that feeling. You can give them a scopolamine patch. They'll put it on prior to them having the procedure. We also use this a lot for people who are going on like cruises and things like that, and they're having sometimes like motion sickness. You'll see this used. So mechanism of action, same thing that we talked about. But what we'll see here is that we have a greater effect on that central nervous system than the peripheral. And the way that you can remember that is usually when we give this patch, they put it behind the ear. So think about those effects being closer to your brain, right? So this patch usually is, they're going to put it behind their left or their right ear, and that's where we'll see these meds, that's where we'll see the patch always, okay? So I can use it for surgery, or before I go on my cruise, I need to have my scopolamine patch. Very effective medication. What we don't talk about and what some people don't realize is that it still has those anticholinergic effects. So people will use the patch, or they'll put the patch on, forget that they have the patch on, and then they start to experience dry mouth, or they're on a very long cruise and they keep replacing their patch, and then they start to feel those anticholinergic effects. like, oh, I'm constipated now, I'm bloated, I'm on the cruise, I'm supposed to be cute. So remember, I have my anticholinergic effects, okay? I'm still drying things up, I'm retaining those things, okay? Don't need you to remember how we're doing it, just remember that it's a patch and that it goes behind your ear, okay? All right. Parkinson's. So when we're talking about Parkinson's disease, just understand again, one of those diseases that we have that it's over time, right? Something that is happening over time. Again, something that we are not going to be able to stop. We're trying to slow it down again. That's always what we're trying to do with these meds. Sometimes we're very fortunate with some of our diseases and we can treat them. We can manage them with our meds. This, we're just trying to help them with those symptoms that they're experiencing and trying to slow it down as much as we can. So what we think here is that the dopamine levels are decreased, and so you start to see a lot of involuntary movements with these patients. If you ever get a chance to like look on YouTube and look at some of the symptoms that these patients have, like when they're trying to walk or whenever they're walking and they're trying to change direction, like how their brain has to try to think about it because their body is no longer moving the same. So a decrease in dopamine, which makes it difficult for me to move, okay? And you'll see a lot of signs that will go along with you talking about Parkinson's. When we're looking at this, our treatment is essentially us trying to increase the levels of dopamine as much as we can and then decreasing the actual cholinergic activity that they have, which is why we're using our anti-cholinergic medication. Again, it's not going to be something that makes the disease go away or a cure for it. We're just trying to keep these symptoms at bay or manageable as long as possible because their quality of life gets affected like very heavily with this disease. So when we were talking about low levels of acetylcholine, what disease were we talking about then? So when we're talking about low levels of dopamine, we're going to be talking about Parkinson's, okay? So remember which drugs go with which disease and what has caused that to happen, okay? So the other part of this too, and it just kind of goes on with the dopamine levels, is that we also think that they're having too much of that acetylcholine over time, and so when I take my anticholinergic, I can also decrease the amount of that firing that they're experiencing and help them kind of, which is our cholinergic activity that we talked about, the acetylcholine firing, and then kind of help them not have as much freezing and a lot of the things that they'll have, the tremoring, so their hands, even when they're at rest, like they're gonna shake. They'll stutter step when they first start walking, like taking really little small baby steps, and so their movement is like greatly inhibited. And you'll start to see, like as the patients keep coming to you, they're not able to move as well as this disease continues to go on despite our medications. So the two meds that we have are going to be your benztropine and your trihexyphenidyl. Mechanism of action, again, more about working on that central nervous system, trying to help our acetylcholine be balanced with the dopamine so that we don't have all of these tardive movements and involuntary movements that they're having. So when we use these medications, we're usually using them in conjunction with other meds that we'll talk about later when we're talking about Parkinson's. So we'll use them with like levodopa, which is one of the meds. So a lot of the times, conjunction when we're talking about looking at this medication. And then our adverse effects, the same anticholinergic ones that we talked about before. So when we're looking at our chart, again, look at your medications that you have, and then your comments. Don't worry about the doses. What I wanted to point out here is that when we're looking at your useful and extrapyramidal symptoms, or you'll see this also abbreviated as EPS, except for tardive dyskinesia. Okay, so when you're talking about EPS symptoms, these are several different movement issues that someone could have, and then it's broken down, and you'll see this when we get into our next lecture. So for now, I just want you to remember like how the chronic is, and then we'll break down different ways that like the difference between TD and EPS, okay? So TD is more so like a tic that that person may have. The tardive dyskinesia is TD. Whereas your EPS is going to be more like some type of involuntary, some type of a different type of movement, which tics are also involuntary. So that's why I was saying like your EPS is the bigger umbrella, and then TD would fall under EPS. Okay. And then you see your trihexyphenidyl, again, not for tardive dyskinesia or akathisia, which is another type of EPS that that patient could have. All right, our NMBAs. So if you do surgeries, you are likely to touch these medications. You're going to see this again. We're going to talk about this again in our anesthesia lecture. But these are very good medications. Sometimes you will also use these. You can put like a nerve block in. When we talk about like a nerve block, that's also kind of falling into depending on how they're using some of these meds. So we're going to look at different NMBAs. So when we're talking about this, we're trying to again block that and the nicotinic or our cholinergic essentially receptors that we have. So looking at this, you can see that like if I want somebody to just relax, right? A neuromuscular blocker. Just remember muscular blocker, right? I'm stopping your muscles from moving. So if I'm working on a certain area in your body and I don't want it to move, I can give you an NMBA. If I am trying to intubate somebody, I need probably going to try to give them an NMBA, and that's if you have time. Because sometimes when you're trying to intubate somebody, you may not have time to give them that neuromuscular blocker, and you're just going to go in. You have to fight against their body's natural reflex, which is like, get out of here, like, what are you doing? Versus if I block that, I have a smoother glide in whenever I'm putting my tube. So this is a nice thing to have whenever you're trying to intubate somebody. Our ventilated patients, typically we know that we're going to put them on a vent, so you'll see where they don't, so that we don't have them buck the vent or breathe against the vent. We'll give them an NMBA to try to like let them relax and let the machine breathe actually for them. Okay, and then just like I told you about the surgery, big thing here that you need to remember is that this is not something that's helping with their consciousness or their pain. So they're going to be up and they can feel it. There's other medications that you have to give them for that. You're going to have to give them pain meds, okay? And you're going to have to give them something if you don't want them to know what you're doing. So just imagine like being frozen and awake and you can't move, okay? Nightmare, all right? You don't want to do this. It's not nice to do it, okay? Especially if it's like a big procedure, all right? Give them something for their pain, and if it's something that you think could be traumatic, right? So where they like have trauma from whatever that procedure was that you did, knock them out. I can't remember anything. We have lots of times where we try to affect their consciousness and they wake up during anesthesia, right? And then they remember what you were doing. This happened to me when I was having a C-section. They were cutting me and we're awake, right? We're conscious, but they didn't manage my pain. I was like, I can feel all of that. Please help. Stop. And they're like, are you sure? Do you want me to cut your stomach? And then let's see if we're sure. Okay? So make sure that you are understanding that if you're just giving them an NMBA, you're just making them not move. Okay? Other meds, and we'll talk about some of those, but those other meds need to come on board when we're doing anesthesia to like fully cover our patient. All right? Structural analogs of our acetylcholine, and they're going to be non-depolarizing or depolarizing, so we're going to go over this because it's a little trickery, right? Like if I'm mimicking acetylcholine, why am I not moving? Why am I paralyzed, right? So it's kind of what we were talking about before, and we'll go over that. So this is giving you a detailed picture, essentially, of the mechanism of action and kind of what's happening. So you have that signal that's going to come down that axon through those voltage gates, and then they're going to go through the synapse, and they're going to connect to these muscle fibers. And then remember, they're mimicking our acetylcholine, and so they're going to prevent that acetylcholine from actually binding there. So now I don't have that movement. Trojan horse, right? I took up your spot. So now you can't bind to that receptor because I got here first as the NMBA, so now acetylcholine is not going to be able to fire. Okay, can't bind to it and fire. When you look at your depolarizing or your non-competitive, the only one that you have that falls into this category is going to be your acetylcholine, and it's not reversed by your acetylcholinesterase inhibitors. There's no antidote when we're talking about this. And it's going to be one of your ones that you'll also classify as short, So this is one of your ones that's like an indirect antagonist, okay? When we looked at this, just kind of, you can read through this in more detail. I just want you to remember, and we'll look at it, but essentially it's gonna be on that receptor, and therefore your acetylcholine is gonna be blocked. So if I'm looking at that, my acetylcholinesterase inhibitor is negligible, like it doesn't matter. It's not gonna reverse any of my actions that I have here, right? Because I'm not directly dealing with acetylcholine. So when we look at that, it's not allowing for that repolarization to happen, so that's why you see it as a depolarizing agent. It sits at the junction to have that constant depolarization, and therefore it can't make any more impulses because there's no repolarization. There's no free receptors for that to happen, okay? So it just stays in that depolarized state. And then eventually they become unresponsive, and then you have the paralysis that we were trying to achieve, okay? So repolarization is blocked. So when you look at this, I don't need you to remember all of this, just remember phase one is like blocking that the repolarization, so it has the depolarization block, and then phase two is like, because that depolarization agent is always there, it's desensitized, so therefore over time, like it hung around for such a long period of time, the depolarization is decreased, and then it's very hard for you to overcome that depolarization over time. So the longer that you expose the person to this medication, more side effects, and the more difficult it is for you to get back that repolarization that we need. Okay, so you see that it is now desensitized and resembles a non-depolarizing block, which is the meds that we're going to talk about next, that may possibly be reversed by the cholinesterase inhibitors in its late phase. When we're talking about you initially administering it, not likely for that acetylcholinesterase inhibitor to work, which is what I was telling you on the previous slide. All right, this is our non-depolarizing. So essentially, like looking at depolarizing, right? I told you you only have acetylcholine. That's the only one that falls there. When you're looking at your non-depolarizing, this is going to be all the other meds that we're going to talk about, okay? So it's kind of like, who got there first? If I get there before you, now I can't have that depolarization. If I don't have the depolarization, then I don't have the stimulation, which means I don't have that movement. I'm paralyzed, okay? So that's essentially all this is saying. When we talked about competitive, remember, if I can increase my acetylcholine concentration, I can overcome the blockade of this, okay? So that's why with my competitive, I can typically use my acetylcholinesterase inhibitor to overcome the effects of that, or to reverse the effects of this if I gave too much. Okay? So does this make, we're good on this so far? Okay, these are your mechanisms for your non-competitive and your competitive, your depolarizing and your non-depolarizing. And now here are our meds that we have. So when we talked about this, we said our acetylcholine was the only one that was depolarizing, okay? And then you see that this is different when we're talking about our elimination, because it's eliminated by hydrolysis of those cholinesterases, okay? Now, the way that I like to remember this, acetylcholine is short, an S with an S. Long, I have my pancuronium, right? Pan expands across several things, so it's very long. And then the other one is in between. So I remember my short, I remember my long, and then I remember if I see rhonium or ium on the end of something, okay, cool, now those are probably my intermediate, okay? So your acetylcholine is short, your pan expands across several things, that's long, and then everything else kind of falls in between. So again, just these are classified by their onsets, essentially. So this has a very rapid onset, so if you're thinking about something where you're trying to quickly intubate somebody, things like that, where you need them to be paralyzed quickly, and you know that that's not going to be something that's a very long procedure, this is, we can say, oh, I need my acetylcholine, let me use that. You'll also see rock used sometimes, so these are the ones that you're typically seeing. I have not seen them use this yet while I have practiced. But again, I was in the hospital for a year with my residency, and I never saw us really using this one. So just remember what class essentially they're falling into. So you're short with your acetylcholine, long pan goes across, and then everything else is in between. Okay. Look at your elimination so that you understand. If I have a patient who has renal impairment or hepatic issues, probably not going to want to use my vet, right? Because it's going to stay around even longer. Now my PK parameters that I thought I should expect are going to be longer than this. They're going to be higher. And therefore, I'm going to have my person paralyzed for a longer period of time than I may need to, depending on what procedure I'm doing. Okay? So look at that to try to just, glance over so you can see, all right, which ones am I worried about renally adjusting, hepatically adjusting? All right, Botox, or your motor nerve blocker. So when we're looking at this isn't necessarily an anticholinergic per se. It's a neurotoxin that is stopping the release of our acetylcholine. Okay, so honorary anticholinergic. All right. So when we're looking at this onabotulinum toxin A, or Botox, this is the brand that we typically carry across several different MTFs. Depending on where you are, the pharmacy, if you're using it clinically, the pharmacy may make you come to the pharmacy to pick it up every time your patient checks into your clinic, because we were having diversion in Botox parties, because people would be like, yeah, that person came for their appointment and they never showed up, and then they were using the Botox because they didn't want lines in their face. Okay, so depending on where you are, some of this will be very, very restricted. There are some places where they'll have the patient have to walk over there with a nurse from the clinic so that we could actually see that there was a patient that actually exists, that was there, and then walk back over with them. Different places may have different waste procedures, so you may not use this whole vial of Botox for whatever the procedure is that you're doing, and so how are they wasting it? Because some people were using the leftovers as well. So depends on where you are on how this is going to be stored in the chain of custody kind of thing. But essentially this comes from a bacteria, and again, like I told you, it's kind of stopping the release of the acetylcholine from those fibers, those nerve fibers, okay? I don't need you to remember the way that it paralyzes and how it would come back, but just understand that this is a thing that could potentially, depending on how it's used, cause systemic paralysis as well, if you use it as that type of toxin. These are several different types that you have of Botox, but I want you to specifically focus here on this one, okay? And then look at all of the different indications that I have, okay? So any type of spasticity, so if I want that spasticity to stop, if you have people who sweat a lot and very easily, you can also give them Botox injections to help them not sweat as much, because it kind of freezes everything. The cervical dystonia, so some patients who have involuntary neck movements or muscle movements and spasms, you can help with that because it's going to stop those spasms. And then your, what else? Strabismus, or when patients' eyes are continuing to kind of move back and forth, you're trying to relax that muscle. Or if you have patients who have cross eyes or blepharospasm, you can kind of help relax their eyes to where they're able to now focus, and that muscle isn't pulling to the inner corners of their eyes. So that kind of helps with that as well. Migraines, again, depends on the patients, and that urinary incontinence, again, very good to kind of give them the ability to kind of relax so that they can retain as much as they need to, okay? This is just different injection spots. That's just for you to see how they use it cosmetically, which is what we hear a lot about. What we talk about and what you're gonna see it used for, you're more likely to use it for, is migraines. So they'll do the injections around their head. Also make sure that they don't go and put their PC back on, because if they put their cover back on hard and it hits one of those spots, it can move it from where it belongs, and then it could go to their eye, and they'll have a droopy eye for a minute. And this med lasts for about 3 months. So they might be walking around, okay, with their Botox displaced a little bit. So that's why we don't typically press on the areas where you give them those injections. Also, sometimes if you're doing like abdominal, different abdominal procedures, sometimes you'll see where you'll bring the patient in a couple of weeks before and you can give them Botox like in their stomach to relax the muscles so that if you are trying to like pull something back together, do some type of mesh, that you don't have to fight against their muscles like being so tense and tight, okay? Limitations, you gotta put little small amounts all over their body, depending on what it is that you're trying to do, but you're pulling up with that syringe and you're going in several times. So when you're looking at a higher immune response because of it being something that came from a bacteria that we found, right, that's causing the paralysis, you can see an immune response in some patients who are hypersensitive to it. If it happens, just document it. The medication will wear off. It's not something that is permanent. So we typically will say like, hey, you're gonna have to come in every 3 months, but some of your patients will have to come in every 2 months. Some patients it only lasts for a month. Some patients, it can make their migraines worse. So you just have to remember, talk to your patient, see what their response is to that medication. Your adverse effects, breathing difficulties or dysphagia, if somebody has that distant spread that occurs, so depending on where you have injected it, if that Botox somehow gets away from that site of administration where you put it, you could see where they would have that breathing difficulty, right? Because now I have relaxed it. I have relaxed that muscle. Pain, tenderness, hypersensitivity, like I told you. So usually the swelling at the injection site, wherever the needle is very small, but you will see like redness at those sites. And if it's not cleaned properly, right, like you wiped with your alcohol pad, you can have the potential, because I broke my barrier, right, my skin is my barrier, of infections that could occur. Your antidote, please take note of this in your adults versus your kids. So when we're looking at our adults, you have the heptavalent, equine, botulinum, antitoxin, whereas in our kids, we have the botulism immune globulin for our kids, okay? So this is if we had to reverse any Botox that was given to them, we can use these 2 agents. All right, what is our parasympathetic nervous system responsible for? Rest and digest, main neurotransmitter. Common side effects that we see with our cholinergic agonists. Read it. Antagonists or anticholinergics. Dry it, or you can remember that very, very long saying. Our drug class used for Alzheimer's disease. Y'all didn't say that with your chest how we were supposed to. We went over it a lot of times. Our cholinergic agonist, okay? And then our drug class used for our Parkinson's. Okay, look, 50-50 chance. Okay, so any of these other slides are all FYI slides for y'all to look at. I think it was focusing on like the aging and stuff like that. So tomorrow we will start with our sympathetic, and I'm also going to post the anesthetic lecture tonight also. Okay? Thank you guys.